Is Dr. Shailesh Gupta, and he'll speak about compartment syndrome.
Good afternoon. I am back again for probably an hour. You have to bear with me. And what is compartment syndrome? This photo describes what is the compartment. Too many things in a small closed contained compartment. Closed space. Too many things. That's a operation theater picture. Somebody has drawn it. That there is a one operation theater. Too many things. Lot of people, lot of machine, and all is all congested. They are not able to move out, and they are all getting all messed up with each other. So I think probably a true dramatic graphical representation of compartment syndrome. When I was trying, when I got the message from Vishwas, Dr. Vishwas, that you have to speak on the compartment syndrome, then I started looking at my own records. How many? I probably in 10 years, 15 years, 12, 13 years, I have 4 or 5 cases of compartment syndrome by my own patients. Is it not so common, or it is was so common that it has been treated everywhere? Why there is not much incidence of compartment? I got with my colleagues. They are all even in the hospital where I work, Arihant Hospital. I don't think there is more than 2 or 3 cases of compartment syndrome we are seeing. So what had happened to this diagnosis? Are we misdiagnosing it? Are we diagnosing it? I think with the advancement in the orthopedic and awareness, probably era of bone setters is getting down and down. So one of the reason for reduction in that, they are not going to the bone setter very often. It's one of the definition. I put this on a ISSH WhatsApp group. I want inputs from the compartment syndrome, your experience. How do you measure the pressure? One of the definition in that group was, this is the one of the condition in which if you doubt it, there is no doubt about it. Just do it. If you doubt it, there is no doubt. You just do that. The cost you have to pay is scar versus the limb. So the best thing is a clinical diagnosis. We'll discuss this thing. It's mostly a theoretical talk. I don't have the much operative picture, but to know the theory is very important. Nothing great in the surgery, nothing great in the clinical picture. We'll discuss something like classification, definition, anatomy, etc., etc., and how many of us are using pressure management. It's measurement. It's well known, written in the book. But what is the current scenario in India? There are compartment syndrome has been classified as acute compartment syndrome, ischemic contracture, that is sequelae of the compartment syndrome, chronic exertional compartment syndrome, chronic compartment syndrome, subacute compartment syndrome. But my talk will be limited with the acute compartment syndrome. How do you define the compartment syndrome? Again, that artistic diagram, a limited envelope in which increased tissue pressure produces reduced tissue circulation by reducing the arteriovenous gradient, resulting into abnormality of the neuromuscular function, which resulted into the anoxia of the tissue, leakage of the calcium, sodium into the tissue, that cause all the sequelae and problem with the compartment syndrome. How do you define the crush syndrome? Compartment syndrome that leads to the systemic symptoms relating to the muscle necrosis and the rhabdomyolysis. A compartment syndrome which has caused the muscle necrosis, and that muscle necrotic product has been released into the blood, which is causing the problem of the crush syndrome, like acute renal failure, myoglobinuria. These are all the manifestation of the crush syndrome. Like hyperkalemia, acidosis, which resulted into the renal failure. Because of hyperkalemia, cardiac arrhythmia, shock, and death is possible. So this is how the sequence of crush syndrome goes on. If you talk about the specific compartment syndrome of the hand, there are thinner compartment, These are the thinner compartment, these are the hypothinner compartment, the interosseous, adductor and the central palmar compartment. When you talk about the volar compartment, there are volar compartment, that is superficial, deep, dorsal compartment, even the pronator quadratus compartment has been described, and anconeus compartment has been described. When I was preparing this article, this talk, when I went to the journal, but it is not, though not related with the acute compartment syndrome, there are some cases of chronic pronator teres compartment syndrome has been reported. It's exertional compartment syndrome. Similarly, anconeus compartment syndrome has been reported. They are able to diagnose because it is exaggerated with the working, and when they measure the pressure, there was increased pressure in that. The compartment, there are variety of the reason where you can get the compartment syndrome. Anything like bleeding into the compartment, major vascular injury, anything which increases the content of that particular, may it be bleeding, may it be nephrotic syndrome, may it be even metastasis of the skeletal muscle, leaky dialysis scalena. There are n number of reasons which can leak into the limited compartment, can cause the compartment syndrome. And this is sometime if we are not aware of all this thing, we may miss it. In one of the paper in the Journal of Hand Surgery, they were reported 25 cases of the neonatal birth trauma resulting into the compartment syndrome. And out of 25 patients, 25 new birth, they are able to diagnose only in the one case where the compartment syndrome was released in a newborn infant. So there is a high chances of missing it if you don't suspect it. Another conceptual classification, decrease compartment volume, like facial closure. When you do a radius ulna plating and you do a tight facial closure, there is a decreased compartment volume. Excessive traction. When you do the excessive traction, the all tissue envelope goes in a stretch and then they compress. They can cause the compartment syndrome. Increased compartment content can be due to bleeding, increased capillary permeability, increased capillary pressure, especially when the hemophilics or those who have a bleeding diastasis, who have a small injury resulting into the bleeding in the compartment, that is a cause of the compartment syndrome. Externally applied pressure like tight cast, dressing, splints, and something lying on the limb, patient has a turnover accident, the lot of weight has been on the site of the accident, the lot of weight is put on the hand or foot or forearm or the knee or the leg, that can cause the compartment. When you go back to etiology, majority of the cause of compartment syndrome is a fracture. Soft tissue amount to 23% case. Anticoagulant bleeding diastasis can cause 2.5% case, and crush syndrome is 7.9%. But when you look into the Indian scenario, this may be one of the reason in Indian scenario. So you have to keep this in. These are the Western data available, but management by bone setter probably supersede more than anything else in India. And second thing, injection injury, extravasation. The venous line has been extravasated. There is a lot of IV extravasation in India because of poorly monitored and poorly applied. These two things probably goes more in Indian circumstances than anything else. What is the tissue tolerance of the ischemia? Muscle tolerates well up to 4 hours of ischemia time. They become uncertain by 6 hours, and after 8 hours, irreversible damage happens. So in one of the talk I was listening to that, when should we not attempt to reduce, release the compartment? When there are changes of rigor mortis, when the limb start a fixed contracture, the tendons are not stretchable, the muscle are not stretchable. These are the patients who should be absolutely contraindicated for the compartment syndrome release, because if you release them, the dead muscle the dead tissue will go into the circulation and you may lose the life of the patient. So these are the not the patient. How much the nerve tolerate the ischemia? 1 hour only conduction block, 4 hour neuroplexic damage, 8 hour irreversible damage. So more than 8 hour of the compartment syndrome. If you want to later on reconstruct the nerve, probably you need a nerve graft and thing. What are the clinical signs and symptoms? Pain out of proportion, pain with the passive stretching, tense compartment, that is a stony heart, hyposthesia because of the loss of the conduction in the nerve, muscle weakness. Remember, here the elevation increases the pain. The moment you increases the limb, the pain increases. There is well established 5 P's, that is pulselessness, pallor, paresthesia, paralysis and the pain. Few tips. Color of the finger may be unaffected. In the early compartment syndrome, you may not see the color change because a palpable distal pulse or detectable Doppler flow does not rule out the possibility of early acute compartment syndrome. So it has to be judged clinically. Arteriography is valuable only to rule out the suspected arterial injury. It is suspected, right? Brachial plexus injury, head injury, intoxication may not report pain. So in that case, a careful palpation by hand palpation to know the stony heart filling. Here the role of pressure gauge measurement come. And regional anesthesia of long duration can mask the one of the patient, which I want to share the experience. I operated, though it was a lower limb compartment syndrome. The patient has a interlocking TBI done, and after that, because of some reason, some bleeding happened, and he was put on the epidural block. Long duration of no pain. By the time patient came to us, it was already full-blown compartment syndrome, more than 8 hour duration, with all ischemic changes appear, and ultimately he went up into the amputation. So you have to be those patients who are operated long, at least you have to have a routine palpation of the calf and forearm muscle. Here the intracompartmental pressure monitoring is necessary whenever the diagnosis is in question. There are various pressure measurements available, and whether it is suitable, it is available in our circumstances or not. Again, I conducted a survey for this talk in Indian Hand Society WhatsApp group. I put this question to everywhere. First time I got no reply. Second time I got some personal communication that I cannot quote, but it is in our department, but we are not using it. Third time I got another reply from Dr. Tahir Ansari from All India Institute, who has written officially on the WhatsApp group. They are using it only for chronic compartment, a chronic exertional compartment syndrome, not in acute setting. So in Indian circumstances, in acute setting, nobody is using. Where it is available for pressure measurement devices, I don't know. Somebody said they were trying to get in New Delhi for a striker, nothing is available. When I was in training in Louisville, I have not seen one pressure gauge over there. CT MRI has no value in diagnosis. Whenever in doubt, don't waste your time for 2 hours in CT and MRI. If there is a clinical judgment, clinical suspicion, just go ahead and release it. What are the prevention and pre-surgical treatment? Correct the coagulation factors if it is because of the bleeding diathesis. Maintain the extremity at heart level. This, why it is important? If you see that the least pressure, actually this is not working. If you see that the compartment pressure is the minimum at the foot at the heart level. The moment if you increase the foot level, your compartment pressure increases, and again if you decrease the foot level, the compartment pressure goes up. So at the level of heart, your compartment pressure is the minimum. So maintain the extremity at the heart level, neither up nor down. Avoid potent analgesics because it will mask the sign and will mislead. If you have the moment you have a compartment syndrome, in current social scenario, you will call, okay, I will call one of my colleague to have a look. If you give the potent analgesic, he might get deviated. No, he is not having a pain. The pain is not the out of proportion. I don't think it is so avoid the potent analgesics. Release all circumferential dressing. That's a one study which was conducted. With intact cast, the compartment pressure is 70. Then you cut the cast, it comes to 50. Then you spread the cast, it comes to 30. Then you cut the soft roll, it comes to 20. Then you totally cast off, it comes to 10. So the importance of going down to cut at all level. It's not that अभी तो ठीक है, अभी ज़्यादा कुछ नहीं. You cut all this thing. It's actually a measurement done in the lab and maintain the blood pressure. If you don't maintain the blood pressure, with a low blood pressure, low compartment pressure will cause a compartment syndrome. So what are the indication of fasciotomy? This I have concluded from the Green's textbook of hand surgery. Normotensive, patient is having a normal blood pressure plus clinical finding plus 30 millimeter of more than 30 millimeter of Hg intra-compartment pressure, which we don't have in Indian scenario, and plus duration of less than 8 hours. Uncooperative, unconscious patient, here the role of measurement of intra-compartment pressure come, but again in Indian scenario we are handicapped by this. Low blood pressure with compartment pressure less than 20. With the low blood pressure, compartment pressure also down with symptoms. Clinical compartment syndrome regardless of the pressure. That should be the key take home. I think you all are aware of it. I am not adding anything into it. When it comes, relieve all the external pressure, remove tight bandages, scar, reduction of the fracture if unreduced. IV mannitol has a role in reduction of the swelling and edema. It works as an oxygen radical scavenger, effect of reducing the ischemia and reperfusion injury, and it has a hyperosmolar capability. So IV mannitol has a definite role. It has come into the textbook for the management of acute compartment syndrome. The fasciotomy, subcutaneous, it's condemned nowadays. Open fasciotomy is required. Emergency fasciotomy without extinguishing the limb and preferably without tourniquet. All muscle compartment are released if required. Epimysiotomy if muscle remains pale after fasciotomy. And in the forearm, laceratus fibrosis has to be released. Concomitant arterial injury, if there, should be explored and repair. Thrombectomy or vascular repair and grafting, and simultaneously nerve repair has to be done. This is unusual case of compartment syndrome. It is the gynecologists use very often the intravenous iron. Gynecologist uses this is one of the case of extravasation of the iron after IV use. The thing is congested over here and here, in the compartment was tense. So I based on this clinical, I immediately released the compartment syndrome. Just a simple 10 minutes job, and it has a uneventful recovery. How do you do the fasciotomy? There are variety of incision has been described. This is probably the lower one is the best because it releases the carpal tunnel, it covers the ulnar nerve, it covers the median nerve and gives the sufficient exposure for all this thing. It's one of the case of extravasation of the IV fluid. The child came and with risk of septicemia, and we released the compartment. I don't have the long-term follow-up. Once everything healed, he never came back to me. Whether there is a changes of EIC or not, I don't know about that. What are the contraindication? More than 48 hours of duration. That's something I have taken, but I don't feel that whenever the clinical signs, there is stiff stiff joints, not able to move actively and passively, limb cold and insensate, no stretch pain, infected blister, should be very careful before touching for the compartment release. Thank you very much.
Thank you, Dr. Shailesh, for your excellent presentation, and I think the